Okay. One of the other things we would often do, and is a very important part of our management, almost all of our infantile Pompe patients have significant trouble with feeding. And even if they are able to have the muscle strength to feed themselves from a bottle, the worry is that their swallowing may be unsafe and they're at risk of aspiration. Significant aspiration pneumonia may, in fact, be a life-threatening complication in these children. So our general approach is to say, no food by mouth until we prove that that's safe. So we're typical pediatricians being very pessimistic and paranoid, but that is our general approach. So until we're sure that it's safe for you to feed orally, we stop it and then gradually reintroduce that with careful speech and language and, therapy and swallowing assessments. I see there's a talk later on today by a speech and language therapist, so I'll not get myself in trouble and say anything more, but this is a very important part of management. Physiotherapy, we have physiotherapists in the audience, so I'll be careful about what I say. It's a very important part of management. In part, sometimes these children need chest physiotherapy if they struggle to cough properly. These children are, as we've noted, very floppy, although having other developmental needs in terms of their ability to improve from a cognitive point of view, to interact with their surroundings, and that is limited by their physical ability. So it's very important for a variety of reasons that we encourage these children's development. And as often, they're stuck in hospital for 3, 4, perhaps much more, 3 or 4 months, or perhaps much longer with the original diagnosis. We need to really look after their development in hospital, because as much as we would like it to be, hospital is not a nice place for children, and they don't tend to develop normally in hospital. There'll be lots more during the meeting about support for the family. It's an incredibly important part of what we should be doing. Infantile Pompe disease is clearly a life-threatening condition, and there's this huge diagnosis to take on board pretty rapidly, and to then take on board that you need to be on this treatment, which may be lifelong, etc. So a huge amount of information to process for the family. There's often a prolonged stay in hospital, often many, many miles from home, and there's genetic counselling issues as well. There's several sessions later on about this sort of an issue, and I can't emphasise how important this is. I think it's just important at this stage to mention one of our practices. Putting a drip into a small baby who's pretty sick, who's had lots of blood tests in the past, every week or every other week can be challenging in itself. In fact, it can be very challenging. So our practice, usually after a few weeks of enzyme replacement therapy to try and stabilise the child, is to insert a portacath, which is a way of having a permanent drip or cannula, if you like, and I'll show you one in a minute, as a way of aiding enzyme replacement therapy. This is a particularly important issue and a tricky issue in the infantile patients. We know that they don't tolerate general anaesthetics at all when they are in the initial phases. Some of the anaesthetic agents can have a very significant effect on the heart muscle and cause rhythm disturbance. And to do a general anaesthetic, you have to ventilate someone, which is not really what you want to be doing in these very unwell individuals. And so we have got round this. Here is an example of a portacath. I hope you can see it. It's simply a reservoir with a little membrane that sits underneath the skin, and a long tube that goes into one of the big veins. This is used very commonly in a whole range of different conditions, but usually goes into one of the big veins in the chest and sits under the chest wall. Our practice, and this will differ in each centre, so don't assume this is what everyone will do, is to avoid doing a general anaesthetic and to use one of the big veins in the leg. So the reservoir sits under the skin here, and that wire goes into the vein here. And how we do this by avoiding a general anaesthetic is to do a spinal block, as like many women get in pregnant labour, etc. So we sort of anaesthetise the child from about here down with a needle in the spine, numb up the legs and the lower part of the body. The child still is able to breathe for itself and is conscious, but can't feel anything that's going on down here. And this is one of our approaches which we have found to be really helpful to our management, and avoided the sort of every other week massive struggle you can sometimes get to get a drip in children who are really unwell. And so that's something that we find very helpful. There has been concern near the nappy area of a child is not a place to put something you don't want to get infected. That is a very important practical issue. Our experience, where we've recently reviewed all of our cases and we've never actually had infection in any one of our patient's ports, which I think is down to very paranoid nurses and parents trying to avoid those things, and I think that's just very good care that has resulted in that. Okay, so our child, I may be wrong now, Joe, we may have more than 8 weeks of enzyme replacement therapy on weekly doses. And we have started to see an improvement in the heart muscle. The cavity, the space in the middle of the left side of the heart is now bigger. The child's on less oxygen and has more movements in its limbs. So we are clearly seeing a response. Clearly, I cannot say whether that is because we've used weekly dosing or, it's a trial of one patient, so there's no way on earth you can say what we've done, is that right or not? You simply can't say. And again, this is perhaps where things like the registry can come into play. All of this information and data is recorded, and you can then start to compare patients. Okay, that's my first case. Please stop me if there's any questions at any point.